Juan Santamaria. I'm a surgical oncologist with UNMC. Today I will be discussing intraoperative radiation therapy for early stage breast cancer. And when I say IORT, this includes radiation delivered in the OR exclusively and no other forms of APBI. For disclosures, I have no financial disclosures. It is important to note that we currently do not perform IORT at UNMC. And some of these materials that I present today were kindly shared by one of my mentors, Dr. Janie Grumley, over in Los Angeles. So the objectives are to provide an overview of IORT, the current evidence for APBI in breast cancer, to discuss the 2016 ASTRO consensus on APBI, accelerated partial breast irradiation, and to go through the current evidence for IORT in breast cancer. So I would like to start with a case. This simple case, this is a 55-year-old female who was found to have a right breast mass on screening mammogram. Ultrasound confirms this to be suspicious, and the biopsy proves to be breast cancer. She's a C-cup, and this is the location of her invasive cancer. She has a grade 2 invasive cancer with no lymphovascular invasion, is ER/PR positive, HER2 negative. Axilla is clinically negative, so she's staged as a clinical T1b N0, stage 1A breast cancer. So treatment options, and in theory, mastectomy versus breast conservation, but we will all agree that there are equal outcomes, that mastectomy is not necessary in this patient. And study after study has shown equal outcomes in mastectomy versus breast conservation, followed by whole breast radiation. So I will not dwell too much on this data, but the premise is that we all agree that this woman will benefit from breast conservation as being 55-year-old with a stage 1A hormone positive breast cancer. So what kind of breast radiation do we recommend adjuvantly? So there is a traditional conventional whole breast radiation. There's hyperfractionation that I think is more now standard. And there's APBI. Different modalities exist, the external beam or interstitial brachytherapy. But is there a role for APBI with IORT? And is there a role for remission in this patient? She does not fit the prime 2 or CALGB 9343 population because of her age. But there is a role for remission in some women, according to those data. I'm not going to dwell on. As Dr. Wall alluded, some of these data already in his presentation, for a long time, whole breast has been the standard of care. Radiotherapy to the conserved breast halves the rate of disease, local recurrence, and reduces the breast cancer death rate by about 1/6. And these are the strongest data to indicate this by the early breast cancer trialist group. And I think he presented the update from San Antonio Symposium a few years after this. And I will believe that for early breast cancer, hyperfractionation is now preferred versus conventional whole breast. And this is supported by strong level 1 evidence data coming from Canada and the UK, with the 15 fractions to 42.5 gray in the Canadian schema, or the 15 fractions to 40 gray like in the START-B UK, with or without boost, with very mature 10-year data showing local recurrences around 5%. Also, not only local recurrences are similar to conventional whole breasts, but the data from the START in the UK suggests that hyperfractionation significantly decrease breast shrinkage, induration, edema, and skin changes, so cosmesis is better. And even pushing hyperfractionation even more forward, more recently, the UK published their 5-year data on the fast-forward regimen of whole breast hyperfractionation, which is 26 gray given in 5 fractions over 1 week. And that suggests that this was non-inferior to their START-B regimen of 40 gray and 15 fractions. So what's APBI? Entrance APBI, I'm going to focus mainly on the IORT modality, but IPBI can be given again via external beam. The data for this include the RAPID trial, the UK import law trial, and more recently, the Florence trial. APBI can also be given via brachytherapy, and these data mainly come from the GEC Estro trial and the NSABP B39 trial, which was a brachytherapy trial, and the Budapest trial. And lastly, for IRT, and for the interest of this talk, and I'm going to discuss in more detail, are two randomized controlled trials, the Elliott trial and the Target trial, and these are the references. As you are probably very much aware, and again, full disclosure, I'm not a radiation oncologist, I'm a surgical oncologist. In 2016, the ASTRO published their latest consensus on breast APBI, which was then updated from 2009. In these guidelines, they lowered the age to be suitable to APBI to 50 years from 60. Included the low-risk DCIS per the RTOG 9804 randomized trial that randomized low-risk DCIS to radiation versus observation. And these were DCIS that were screen detected, small, less than 2.5 centimeters, and with a wide margin, and intermediate, low to intermediate grade. It also addressed the IRT recommendations. That was a new key question. And as a surgical oncologist, I need to note that this consensus was endorsed by our society, the Society of Surgical Oncology. So the 2016 ASTRO guidelines suitable patients for APBI are those that are older than 50 with a good surgical margin clearance after lumpectomy of more than 2 millimeters, those that are node negative and that are a T1 tumor, less than 2 centimeters, and also as mentioned as a low risk DCIS per RTOG 9804. The unsuitable patients are those younger than 40, or those between the age of 40 and 50 not fit in the cautionary criteria, those with positive margins, or those with a bigger span DCIS, more than 3 centimeters. And the cautionary patients are those between ages 40 and 49, and those that are older than 50 with at least one of the pathological factors listed there, and some of those that will confer the patient a higher risk, like ER negative or multifocality, lobular histology, etc. Those with a close margin, less than 2 millimeters, but not tumor in ink, and a DCIS of less than 3 centimeters span not meeting the RTOG data. Those are the cautionary. So what does the NCCN tell us in the latest version? I think it was updated a few weeks ago. And there are recommendations for APBI that suggest that it's comparable to whole breast. They suggest that the data on cosmetic outcomes is not completely clear because these studies are heterogeneous, and some APBI regimens are daily, some of them are given twice daily, some of them involve brachytherapy, interstitial balloons, and so on. But they do include 4 studies and 4 data. 3 of them external beam, and 1, the NSABP B39 is with the balloon interstitial. And of this, actually, the Florence trial, which is the latest, is the preferred. So there is actually no mention of IRT currently in the NCCN guidelines for breast cancer. It is worth to note the Florence trial, that it's a very incredible data, 10-year data coming out of there, in which patients were randomized to whole breast versus APBI given to 30 gray and 5 daily fractions, with a sub 5% local recurrence in both groups at 10 years. So the new key question in the 2016 ASTRO guidelines that they wanted to address was which patient may be considered for IRT PBI. And as one can deduct, IRT can be considered attractive to patients due to different reasons. The radiation is given in the OR at the time of lumpectomy in a single fraction, so it is very convenient, highly convenient for patients, especially those who have limitations to access a radiation center. No catheters or balloons are left in place, and this decreases potential wound complications or issues that arise from the brachytherapy or the interstitial of the balloons. And then this is also thought that IRT can improve cosmesis. It is radiation like APBI that targets a tumor bed, which is the most common site of recurrences. Data for these are mainly from 2 randomized controlled trials, the Elliott trial and the Target trials that I will discuss in more detail. So the first one is the Elliott trial, which was a single center Italian trial and that randomized 1,305 patients with invasive cancer to a single fraction IRT given in the OR with electrodes. This was a linear accelerator placed in the OR versus whole breast, so up to 6 degree, including a boost. The age range was 48 to 75, and the tumor sizes were less than 2.5 centimeters. However, many of these patients were biologically high risk with some lobular features. A fourth of these patients had nodal involvement and who all underwent a complete axe dissection. And some of these patients were also estrogen negative, which makes the patients at least by astro cautionary. Many of the patients of this study also were not suitable, therefore, because of all these reasons with the current astro guidelines. So a very heterogeneous group of patients. The data was published in 2 reports. So with all the caveats that I told before, the 5-year data was published in 2013, and this already showed an increase of local recurrence with IORT, 4.4% versus 0.4% in the whole breast group. And the primary endpoint of this trial was to show equivalency, to be equivalent, and they couldn't prove this. Patients with high-risk features, such as tumors that were larger, more than 2 centimeters, or node positive, high grade, ER negative, or triple negative, had over 10% of local recurrence. However, there was no difference in survival at 5 years, with the caveat that, again, this was not the primary endpoint of the study, but rather to show equivalency between IRT and electrodes and whole breast. The 50-year data of Elliott was published actually 3 months ago. This update confirms that IRT results in a higher local recurrence, about in the magnitude of 12.6% versus 2.4%. In a subset analysis of the astro-suitable patients in their cohort, extrapolated a 5-year local recurrence of 2%. However, at 10 years, this was 6.1%. And these are the curves of the curve of the recurrence, obviously different curves. But importantly, at 15 years, same rates of distant recurrence and overall survival, which tells us, well, we kind of know breast cancer, that biology is king, and a local recurrence sometimes does not really direct the biology of the disease. So the Elliott conclusions are that there is a confirmatory, sorry, I'll go back. The Elliott conclusions confirm that the IRT given in the Elliott schema increased local recurrence, and that electron IRT was not equivalent to whole breast radiation. They did also another analysis where very low risk patients that had tumors less than 1 centimeter, low grade, luminal A less than KS67 with very low local recurrences in this subset group. Astro-suitable patients had a 6% recurrence at 10 years. Is this acceptable or comparable to for example, modern hyperfractionation by the Canadians or the UK? It's similar. However, biology is always king, and local recurrences do not necessarily drive the distant recurrence in breast-specific mortality and overall survival. The limitations of this study were that there was a lot of patients that were high risk, that were unsuitable. So the next trial I'll discuss is the Target trial. And in this trial, the technology is different, is the intrabeam size device, which is a low energy X-ray modality given with a cone and with a sphere as shown here with the machine. And there are 2 reports of the Target. The last one was published a year ago. This was a multi-center randomized trial with 2,298 women older than 45 years of age with tumors up to 3.5 centimeters. IRT was given to 20 gray in the OR with low energy X-rays. They established a preset non-inferiority criteria. That was their primary kind of outcome. that IRT was going to have less than 2.5% more absolute percent recurrences than whole breast. That was their cutoff, and this has been very criticized. Again, there have been 2 publications of the target, one in 2014 and most recently a year ago. There was an update, and these are the curves comparing target versus external beam whole breast. And as you can notice, 12 years, there are almost 20% local recurrences in both groups. That is unexpectedly very high for this trial compared to other modern data. There were very high recurrences in both groups. Again, similar to Elliott, biology is king, survivals were the same. This trial was heavily criticized because of its methods, statistics, and the non-inferiority clause that they decided to use. It was also criticized because they combined different subsets of data and modalities, one of which was a post-pathology stratum of patients that underwent the lumpectomy and waited for the final pathology. And after that, then they had reopening of the lumpectomy and the liver of the 20 gray. So that was kind of question, was that really convenient for patients? And is that a convenient IRT? So they do conclude, however, per their data, that cardiovascular deaths were higher with whole breast. But a lot of the schema and the regimens of this trial were more traditional, conventional whole breast radiation rather than modern hyperfractionation with the better plan and designs and those symmetries. So the 2016 ASLO guidelines bring it home. Show that there is an increase. They conclude that there's data that shows there's an increased local recurrence. And the updates of Elliott confirmed this 3 months ago. And Target is showing a very high unexpected recurrence rate of 20% in both groups. That electron beam IRT as an Elliott should only be used in suitable patients, and perhaps a future ASLO consensus that could be coming down the pipeline. I'm not sure, maybe in a few years, could confirm this, that Elliott electrons could be offered to patients with the caveat that there's been a higher local recurrence. And then low energy photons like in Target should be experimental in a clinical trial setting or a prospective registry, and only be used in astro-suitable patients. So this study here, related to this last point for the ASTRO guidelines, is the largest prospective registry in the US for breast IRT. It reports the experience of 1,000 patients treated at Haag Memorial Hospital in Newport Beach. The main author of this paper is Dr. Melvin Silverstein, who's a past president of our society, and he's considered to be a father of oncoplastic breast surgery. And my disclosure is that I trained with some of his mentees. Thus, my broadest breast IRT experience is related to the system they use here, which is the soft accent system. It utilizes an applicator as a portable delivery unit in the OR that delivers low energy x-rays at 20 gray to the surgical bed. And we are able to accomplish this usually between 8 to 20 minutes of added surgical time. So in their data and their registry, only 42% of their 1,000 patients were astro-suitable because they started this study in 2010 before the guidelines were out. 23% of the patients were unsuitable. And in red, I highlight that. Why is that? Because they were more liberal with the age. They did it more than 40 years, and also with tumor size less than 3 centimeters as opposed to 2 centimeters. They report in the astro-suitable patients and their subset analysis a 3.3% local recurrence at 4 years and a 4.4% recurrence in the cautionary or unsuitable patients. And that's there. The technique is quite simple. We're in the operating room. We have performed a lumpectomy. We try to approach as many patients as we can with an oncoplastic approach. We have a balloon applicator to measure the cavity, and to place, we have 3 sizes of the balloon. Once we put in the balloon in the lumpectomy cavity, we bring in the ultrasound and make sure that there's good confirmation of the tissue around the balloon and that there's a good and safe distance from the balloon to the skin. When we do the lumpectomy, we send this immediately to our pathologists together with the sentinel node, and they do a gross examination of the specimen to ensure that we have a good margin grossly, and they do a bisection of the lymph node and grossly to see if it looks normal. So this is one of the balloon applicators. This is a 3 to 4 centimeter Axon balloon applicator that we fill in the cavity. And then we bring the ultrasound again, and we make sure we have a safe distance to skin. We would always try to target more than 8 millimeters distance from skin. And as noted there, this was a 9.1 millimeter distance. Then we bring in the machine, and we deliver the source, put a shield, and then a physicist and a radiation oncologist will be in the OR, and we will deliver 20 gray in about 8 minutes, 10 minutes. So the whole process would add about 20 minutes to the operation. And then we'll remove the balloon and finish the surgery. So, and that's the result post-op. There aren't current really big ongoing randomized controlled trials comparing IRT with whole breast or hyperfractionated whole breast or other modalities of APBI for what is given. But this is one I found that is ongoing in Germany. This is appears to be a good group from Heidelberg. It's a small randomized controlled trial. The primary endpoint is to assess for fatigue following radiotherapy, and their plan for randomization are patients to undergo breast conservation with IRT like an Elliott with electrones, and versus breast conservation and then hyperfractionation after with 40 gray by 15 fractions. So the primary endpoint is fatigue, but other endpoints are local recurrence and everything. So to conclude, breast IRT is not ready for prime time. Future ASTRO guidelines could address these things and change their updates, given the updates from Target and Elliott. IRT with electrons as evidence is a little stronger than with low energy photons. IRT, I think it continues to be convenient to some patient population who are rural, who have no access. But now with Florence Common, which is 5 days of radiation, or even the fast forward whole breast regimens, the question of really IRT is really that convenient if patients can potentially get 5 fractions. IRT role would be better studied and better phase 3 randomized control studies with randomized control trial that studies that I'm not aware of any going, and I don't think prospective registries are the answer to this. So that will be the end of my talk.